Well, hello, everybody. Thanks for joining us this evening, whatever time zone you're in. We're getting together to talk about some challenging tibial cases and also about the Serrator and the Serration technology, that kind of thing. My name is Peter Schneider. I'm a vascular surgeon. I have two top-notch rising star specialists with me. One is Dr. Sameh Sayfo, who's in practice in Plano, Texas, interventional cardiologist, did his fellowship at Brown. I know I've talked cases with him many times. We've worked on projects. He's a lot of fun to get his opinion. And Dr. Neil Poulsen, vascular surgeon from New Jersey, from the Robert Wood Johnson system. And I think these two gentlemen will, maybe have some interesting things to say about where CLTI fits in their practice and what kinds of things they're doing. So maybe I'll throw it first to you, Neil. In terms of CLTI, are you mostly hospital based, mostly outpatient based, and what's the flavor of your practice?
Yeah, of course. Thank you. So I would say mostly hospital based right now. We do have our group has two OBLs, but do we do a lot of dialysis access there? And I personally, at this point in my career, I do feel more comfortable with the CLTI in the hospital, just because you can get access to more options there. I have the wire. I personally like an 014 Advantage wire. I like certain crossing catheters. I like to be able to use, the Serrator device, other devices that just aren't available right now in an OBL setting. And so I think that hospital based, when I see a patient in my office and think, they have wounds, and I'm really thinking there's going to be some complex below the knee tibial lesions, I tend to send them to the hospital more often, or schedule them in the hospital more often.
Gotcha. And well, just before we go to Sammy, let me just ask you, since you're a vascular surgeon, and I'm assuming you're in a mainly vascular
Yes.
surgery group.
Yes.
So where does bypass fit for you guys in the post best CLI era? Do you save it for the Wi-Fi 4, extensive foot damage, or where does it fit in your practice?
Yeah, I think that for me at least, I'm still trying initially to treat these endovascularly if it's reasonable. If I can get through it, I'm not going to spend hours and hours and hours. Like, my first thought would be what's my bypass option? And then how does this patient look in terms of a bypass? If I have a young patient, bad diabetic wound, tibial disease with a great posterior tibial or great anterior tibial target, I'm more inclined to jump to bypass right away. But I'll still try for an endovascular option, but not. I would say I give it a try and then move forward after that.
Interesting. And Sammy, let me throw it to you. I know we've talked about your practice before, but just for the audience, maybe you could give some flavor of what it's like right now.
Yeah, thank you for having me today. And below the knee treatment has been a growing field, and it's been exciting. I don't have we only work in hospital based, and this is how I was trained up north, Brown, and this is how I practice here. I don't know anything outpatient lab. And I think for below the knee, I agree with Neil, because below the knee disease is pretty complex, and you never know what device and what product and what kind of wire you need. So for us, we have all the equipment needed in the hospital. We have a unique setup where we work shoulder to shoulder with our vascular surgeon. We have a great vascular surgeon in our hospital that we work with. I think we select a patient that goes for surgery. Depends. Are you talking about a full SFA, full AT occlusion? That's only vessel. Are they going to bypass more proximal versus very, very distal? In our hospital, our patient population can just more complex, more dialysis patient, more diabetic patients. I don't think so far right now, we're seeing the benefit of weight loss product or the injectable weight loss product yet, because our patient population we're seeing are the 60, 70-year old that they've been collecting calcium and calcification for 20 years. So we're seeing complex patients. Almost all CLI have some below the knee disease. sometimes a combination. And we're learning more and more that just fixing inflow is not enough. So we had to have the, angiosome was the new thing a few years back, and now the woundosome is the new thing. You really have to get flow to the wound, not just a flow to the foot. Um, yeah, we
Yeah.
probably still have a lot of products in our toolkit, and it just select each patient is different than the other.
Yeah, yeah. And also, I was just wondering, maybe one of you or the other may have an idea about this, but I think the calcification that we're seeing seems to be getting worse. Now, I don't know if it's because with better medical management, people live longer, maybe with diabetes or something like that, but seeing patients sometimes who really they aren't even on dialysis, and yet you can see the complete outline of their vessels in a way that, in years past, it just was not very common, and now it is. And so I just have this anecdotal impression that calcium's getting worse. And I think because of that, so for me, plain balloon it's a rare case when I'm thinking that plain balloon alone is the only thing I'm going to need. And I think what's driving that impression for me is calcium. So I don't know, maybe Neil, what do you think? Do you, you probably see plenty of patients that have severe calcification, that sort of thing.
Yeah, I think that the amount of calcium everywhere, not just the below knee segment, is staggering. It's a rare occasion where you have a single, SFA stenosis with atherosclerotic plaque. These patients are coming in where you can do your angiogram without even shooting dye. You know where the vessels are. And honestly, like you said, I'm getting a lot of referrals from primary doctors for patients who had an X-ray for like an ankle injury, and they can see the outline of their vessels. So I think you're 100% right. Calcium
Right.
is going way up, and I agree that POBA is just not. There's got to be something else for it. It just isn't working.
Yeah. And there's some papers coming out now about pedal artery, medial artery calcification, so-called PMAC, and just the amazing prevalence of that, both in our population and in patients who go on to develop CLTI. So I don't know, Sammy, anything else? Anything I'm missing?
Yeah, I agree with both of you. I think our unfortunately first world country in the U.S., but our food quality is not as good, and I think that's contribute to it. But also, what I think is now our vascular specialists, regardless of their subspecialty, IR, IC, or vascular surgery, we're getting more brave to tackle below the knee instead of just chopping a leg off. I think in
Yeah.
the
Hmm.
past, you look at it, I can't bypass it. I don't think it's gonna work. It's gonna fail. I don't have option. Balloon doesn't work. And then just people just and that data is there that, the very high percentage of the United States patients receive an amputation without even an angiogram or an intervention. I think now the mindset has changed, and that's because now we have equipment and devices that allow us to tackle this. I think also we'll give credit to physicians who want to tackle this, and now we're dealing with this. I
Yeah.
think us want to tackle it, us want to serve our patient with the best possible intervention without amputation and trying to do a free amputation world. I think that's why we're seeing more calcium because we're tackling that one.
Yeah. Yeah. It makes sense.
I
Um,
agree 100%. I think coming out as a newer attending, a newer physician, there's a lot less drive to just, okay, I can't do it, I'm going to do an amputation. I definitely agree with that. The fact that
yeah.
we're doing less amputations definitely drives that.
Well, and to me, it's heartening that we've taken this aggressive approach, but man, sometimes it really feels like you're under an avalanche with some of these cases, and that's
Yeah.
part of the reason why it's good to talk about them and to see what other people are doing. Are you able to see my screen?
Yeah.
Yep.
Great, great. So I'm just going to introduce the Serenator for a moment, and really the concept is creating serrations. So there are other ways of taking on these types of diffusely diseased arteries. And we already mentioned the calcification and the challenges with plain balloon. And the concept of serrations is to try to mitigate or to improve on what a balloon can deliver, but still keep the same concept of the user friendliness and low expense of a balloon type of technology. So the Serrator, you can see there are serrating elements on the outside of the balloon. There are some strips that create this. And it's really sort of like creating a cut along the dotted line. And we know that in plain balloons, with plain balloon angioplasty, most of the lumen is not created by plaque modification or compressing plaques. It's created by stretching the external elastic lamina. And in a case of serrations, the serrating elements are specifically designed to reach the external elastic lamina and to incise it and to allow the artery to open kind of along the dotted line, if you will. And you can see what we have available at this point, 2.5 to 6. More recently, a 2.0 SL Pro was made available, was put on the shelves with balloon lengths for the SL Pro 20 to 120. And then, of course, with the other sizes, we already had up to 120. And these are 6 French sheath compatible for the 2.5 to 6 and 5 French compatible. And I think that the point of the SL Pro is that we really have limited means of addressing below the ankle atherosclerosis. So this is one option for it. And then in terms of, again, just sort of comparing or contrasting what you can do with a plain balloon versus a modified balloon, you can see that when you do the calculations, people talk about focal force balloons because balloons with wires on the outside can generate 20 plus times the amount of focal force that a plain balloon can generate. But with Serrator, because these are serrating elements, because they're actually incising the artery down to the external elastic lamina, when you calculate the force, we really I think of it as point force. And the amount of force generated is 1,000 times what a plain balloon can generate. And when you start thinking about that, then it starts to become more clear why you can put a Serrator up to, say, 6 atmospheres and get a very often an excellent result in a heavily calcified artery, because this is a different design with a different mechanism of action. And you can see this concept here as the Serrator inflates and the serrating elements go into the external elastic lamina. It allows the dispersal of energy in a way that a plain balloon cannot do. Again, it creates almost like a cut along the dotted line and allows it to incise the external elastic lamina and allows for a better lumen with less residual stenosis. And we have some data about that. I'm just going to show you briefly again, because frankly, it's a lot more fun to talk about cases. But here are just some data, quite excellent freedom from CDTLR in the BTK arteries, a substantial reduction in recoil. I'll show you that data, and also a very low bailout stent rate in the BTK arteries. So in this particular paper, this was from Marianne Brodmann in Graz, home of Arnold Schwarzenegger, you may know, in Austria. And in Graz, they did a comparative study between plain balloon and Serrator and found a 49% improvement in residual stenosis. When you do the calculations, again, these are small arteries, so the more you can improve the diameter, since flow is proportional to the radius squared, the more you can improve the diameter, the larger the increase in flow we're going to expect. And also in that same study, they found that when they looked at CTOs, in this third bullet here, when they looked at the lumen gain in CTOs, that actually was an even greater improvement over POBA, over plain balloon, a 62% improvement. And the average pressure in the Serrator was 5 atmospheres. as opposed to POBA, which was 9 atmospheres, which I would say is pretty standard. It's rare for me to do a BTK angioplasty with plain balloon at this point, but when I do, it typically requires at nominal or higher. And just one last slide. We did do a recoil study, which was very cool. Everybody talks about recoil, but hardly anybody does anything about it. And what we did in this study, this was really run by Vanita Chandra from Stanford and Michael Lichtenberg from Arnsberg in Germany. And what they did was a comparative study in 40 lesions, BTK lesions, Serenator versus POBA, and then did something that's nearly impossible, and that is waited for 15 minutes after the case and then did another angiogram. And what they found was that in the PTA cases, that the mean recoil across all lesions at 15 minutes was 55%. So again, small artery, flow dependent on the diameter of the artery or the radius, and found a significant recoil. And this is consistent with what was in the literature before from Baumann. And with Serenator, only a 6% recoil. So a dramatic improvement in the occurrence of recoil. So I'm going to stop sharing now. Hopefully that all made sense. Do you have any questions? I know you guys have all seen that data before, but anything unclear about it, or anything I should have highlighted better?
How did you guys convince an endovascular interventionist to wait 15 minutes?
Oh, I know. And also you have the IRB. But I've had this experience many times where I go after, say, a post-tib. I get what I think is a beautiful result. I'm so proud of myself, but because the patient has a shark bite out of their foot, I decide to do another vessel, a perineal or an AT. And after some minutes goes by and I'm working on that vessel, I take another angio and I see my first result, which was spectacular. 20, 30 minutes ago is not quite as good. So this recoil thing is real. And I do think the serration makes a difference. It makes a difference acutely with less residual stenosis, and it makes a difference at a later time point because of a reduction in recoil. So very exciting. Thanks for asking. Anyway, so I think I stopped sharing, so I think you can go ahead and share, Sameh. Bring your cases
So
up.
I was asked to kind of share a couple of two cases, and those two cases were very specific because I believe that most of us, can you see my screen?
We can.
Yeah, I think so many of us, when we look at the below the knee, we try to kind of be conservative. We'd like to keep it clean, to avoid dissection, and because of the limit of what options we have, if we end up with a dissection, if there are data for utilizing coronary stent in the proximal part of the AT or PT, and there's some good data for that, but you really don't want to leave things behind there because you take away from other options in the future. More recently, you have now many product coming along for bioabsorbable scaffold. And I believe that if you look at the data, now we have live BTK, but many other companies coming up with this. The question is, what if you put a stent or put the bioabsorbable scaffold, is that enough? And we learned the hard way in the coronary world because we had a bioabsorbable scaffold that was taken off the market because of stent thrombosis, because people were undersizing the stent. So those bioabsorbable scaffold not only important to size correctly, but it's very dangerous if you undersize or if you're under prepping the vessel. So the two cases I'm showing is cases where I use serration technology to prep the vessel before I apply the other technology, and that's something I'd love to hear from all of you about. Do you use a serration as a solo treatment? Do you use it in combination with something else? I use serration in other bed. I love serration in common femoral, even though it's a 6 French, but in the osteal SFA where I don't want to put a stent, I love serration in in popliteal. Here's the case. I would love to see what you guys would do differently. 71-year-old male, ischemic cardiomyopathy, history of CABG, so his veins were used for his bypass. Diabetes, former smoker, and was referred because of critical limb ischemia, more of a resting pain. And you know how this patient can really progress very quickly. Just by the time he waited from resting pain to see me in the clinic, when I saw him in the clinic, he basically had a large toe ulcer. So he moved from Rutherford classification 4 to 5 really quickly. ABI and TBI were both abnormal, and CTA was done in the hospital prior to the procedure showed documented some moderate disease in the SFA popliteal, but really severe disease in the trifurcation of below the knee vessels, and documented as a moderate calcification. So look at the angiogram. Common femoral looks good. Proximal SFA looks okay. Distal SFA has maybe 60% lesion. Popliteal has some, aneurysmal changes with some disease as well. But now you see this kind of really ugly looking trifurcation right at the ostium of the SFA and also the perineal. When you look at the distal flow, my apology doesn't, I don't have, as my mentor has taught me, you never show below the knee case without showing the foot, but my apology, I'm not showing the foot here. But you can see that the AT is really the culprit vessel in this case.
Yeah, it looks pretty severe. And also, Sammy, are you, in this case, your intention was to go up and over?
This is an up and over case,
Okay.
correct?
Is that when do you decide to go antegrade? Do you have a particular decision point on that, or?
I mean, patient size really play a big role in my decision. I'm not a surgeon. I don't have the privilege of the groin, cause a problem. I just open it up, and I hate to bother my fellow, vascular surgery colleagues here to come for the antegrade. But I usually do up and over most of the time, unless it's a stage procedure. Let's say I go in, I fix an SFA, I fix a popliteal, I leave below the knee, I know the proximal SFA is clean. I would go antegrade if I need to do. If I need to do arch reconstruction, I definitely go antegrade. I need more room.
Yeah,
But
that makes sense. I think that makes a lot of sense because if you're going to go down to the distal third or certainly into the foot, it just gives you so much more leverage to be antegrade. But anyways, this is a good case, and there's nothing more miserable than a patient in rest pain, and especially if they had to wait to get to you. I'll bet this patient was pretty anxious to get something done.
yeah, I mean, and that's cases like this where you're gonna have to have a stand. Like, should you admit those patients? How can you expedite this case? And this is a conversation that's really hard because you have insurance that have to be approved, and you guys know it now with all the drama about other technologies now. If you want to do outpatient to approve, possible atherectomies, that takes some time. The question I
Yeah.
have here for this case is, would you place one wire versus two wires? Do we do one wire in the AT and the PT, or just one wire system? I just had thoughts, just throw a few questions and see what you guys would do differently.
Yeah.
How would you
Well,
approach that?
I'll throw out an idea and then maybe we'll send it to Neil. But I see now you've got the ankle and most of the foot there. It's hard to tell what the relative contribution of the perineal versus AT, but it looks like the AT is going to be the important vessel, as you suggested. Of course, you know the case, but I would probably want two wires because I'm worried that whatever you do would shut down the other vessel. I don't know. What do you think, Neil?
I mean, I don't know if I haven't done two wires really that much. I would go for the AT first, or go for the PT first. I'm sorry, treat that lesion and then treat my AT, knowing that it might shut down my perineal since that's the less dominant runoff.
Yeah,
Or I
yeah,
would try to use something that would be less likely to do that.
That's
yeah,
exactly what I did. That's exactly what I
yeah,
did. I put two wires in this situation. I kind of treated the PT first just to kind of see how the AT is going to behave. Because to me, I want to make sure that my final treatment will be for the AT, because that's the more major vessel. Plus, sometime with AT looking almost a CTO-ish, maybe it's not filling enough. And if you fix it and take a picture, maybe uh, that vessel may be bigger than what we think it is.
hmm
So I think we answered question number one or two. And what about IVUS? The question: would you IVUS below the knee cases? every other case? What do you think, Peter?
Yeah, I don't use it absolutely routinely, but we're using it more and more. So what I probably would do here is I would probably size it based on, clinical experience and see how that looks. And if there's any question then or any concerns about the result or the sizing, then I would use IVUS, but I don't use it on every case. So I'm looking for a reason to use it typically. How about you?
Yeah,
I
I've
think
been using more and more below the knee. I just
Yeah.
learned that my eye is always undersized below the knee vessel. So I have not used at the proximal AT or PT anything less than 3 or 3.5 now since I started using ibises. I've had cases where it's like 4.5.
Wow.
And then the other thing is there are almost more calcium when you start using IVUS, and that sometimes change the way I intervene on it. So if I see tons of calcium, I might say, okay, maybe I need to do, atherectomy. I may need to use an IVL. I may need to use IVL with a serration. Maybe can I just do serration alone? It just helped me guide
That makes sense.
how
Helps you to
much.
choose therapy. So it's not just sizing, but
Yeah.
choosing therapy.
So Neil, what do you think in this case? Would you do an atherectomy? Do you think there's a role for atherectomy here, or no
I
atherectomy, and why?
just based on my personal experience, I would not. I find that at these origin of these tibial vessels, I get very nervous that I'm going to cause damage at the origin in a kind of a more tortuous area, as well as the fact that the runoff isn't perfect. I'd be more worried about embolizing and getting a filter down into either of those vessels may be more difficult in this case. So I usually will not do it at the origin of the tibials.
I like that. For me, is I always worry about the distal embolization, and those patients has pretty bad distal vessels,
Yeah.
even though microvascular disease is a real thing, and even sometimes when you say, well, there's no distal embolization, but even this microemboli also
Yeah.
can inflame that wound. So we said vessels. So what do you guys think the size of the AT? Peter, what do you think?
3.
3. What do you
I'm
think,
I'm
Neil?
I'm guessing 3. Yeah.
I'd say three as well. Three
All
as
right.
well.
Yeah.
So 2 wires. I ballooned the PT first, or the TP trunk first. Kind of really did not do a good job I mean, it's almost shut down my AT. I wanted to get the distal SFA and the apoptose first, just in case there's any dissembolization or anything I need to worry about. Just fix the bigger vessel first. With the IVUS, actually, it showed the SFA and the apoptose was severely diseased. Was talking about 80 to 90% lesion. We're just not as, it was pretty deceiving because it was aneurysmal vessel as well, or ectatic vessel. What we did is we started with a 4.0 serration balloon on the PT, and then we use it again for the AT. And for the Osprey, actually, I used a 3.75 by 38. The reason I used it, I was worried that even when I finished, did not get, there was this competition between the origin of the AT and the origin of the PT. And I was
Mm-hmm.
worried that my AT will finish up, will shut down. Some physician has shown me a couple of cases that I just have not done. We do a lot in the coronary when we do something called a call out, where basically you do two kissing stand inside each other,
Yeah. Yeah.
and you can basically expand the proximal part. We have two layers of stent. In this case, I just chose to kind of follow the AT, and I'll show you the final picture in a second. But just for the Osprey, this vessel is measured is after the serration is 3.0. It actually measured 3.5. So I put
Wow.
a 7.5 38 Osprey. Just want to show you the why I do IVUS. This is just to show the IVUS pre serration and measure as 2.8 and the proximal part where the vessel was diseased. But when you go proximal, it's measuring almost 4. That's just where that, if you remember the picture here in the initial picture when I showed the right where you kind of see that fat segment here,
Yeah. 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 So
proximal.
that was more than 3.5, that section.
That was more than 3.5.
Yeah.
So I did a
Interesting.
4. As I said, it starts smaller a little bit, not too small. And I think with the serration as well, we've learned that because you go a low inflation, maybe you want to do it the same way we did IVL. We do like 1.1, 1.2 to 1 instead of just doing 1 to 1.
Uh-huh.
You got lower inflation there.
Interesting.
And this is just to show you two wire, and this is the final result.
Yeah.
We got a nice
Yeah.
flow to the AT, and the PT actually stayed pretty happy. And that's a distal vessel there. It's,
Mm-hmm.
reasonable and no distal embolization.
Yeah. Good. And you were able to put the esprit right where you want it, just in the origin
Yeah,
of the AT, the ostium.
correct. I used the IVUS to tell me where the ostium is. I marked it on the screen. Plus the other
Yeah.
wire kind of help out. And then one of the recommendation for Usbury is you have to post dilate with the kind of semi uh, either non-compliant ideally. So in this one, we end up doing an emerge non-compliant coronary balloon, a 4 by 30. So again, this vessel, even though on the Legion, we're talking about a 2.8, it actually 3.7 to 4.
Okay. That's great. Well, that's a lot bigger than my eyeball test, so good for you. Yeah. Great.
Do
Good case.
you want me to jump in the second case? Very similar.
Sure. Yeah. Why don't you show one and one more, and then we'll have Neil show some.
Sounds good.
Perfect. So patient 77-year-old, history of coronary heart disease, similar thing, cabbage, get a right lower extremity angiogram because of the symptom of claudication. And then, the patient actually, his symptom was a claudication. He got an insect bite and it's not healing. So it's not a true wound, but it's basically a wound. And his creatinine was 2.34, so no CT. And ABI was done 3 months before that, was a zero point 0.8 on the ABI. So we did the CO2 injections here. You can see that, the SFA looks okay, not really major. Popliteal looks healthy. Below the knee, initially looked okay. So I did more selective pictures, and we took pictures here, and you see that, the TP trunk is gone, and AT here was deceivingly looking good till you look further down, and you see this kind of really tight lesion there, 99 to almost 100% lesion. And I just kind of zoomed it in to show you maybe there's a small channel there.
Yeah.
So before I go to tell what we did, so Neil, what do you think? What's the best wire to cross a lesion like this?
So, I mean, for me, my personal go-to for almost every baloney case would be an 014 Advantage wire. I like the way that it feels in my hand. I like the way I can control it without a torque device. If I find that that's not going, or the tip is damaged, I will go to a command wire. But those are really the two that I use exclusively.
What about you, Peter?
Yeah,
Same.
for this, yeah, I would usually use a command, but a Gladius is really nice here. It's hard to tell, is it a stenosis or a super short occlusion? So that would also influence, if I went with the wire and I convinced myself it was one or the other, it might influence my choice, maybe use a little bit more heavier tip weight in an occlusion. But there's no way this guy is in good shape. I mean,
Yeah.
with this is a lot of disease, and this is a nice example of getting a great angio with very little contrast, because you ruled out the proximal part with CO2, and then you probably put this catheter all the way probably into the origin of the tibial, or at least in the distal pop, something like that.
Exactly. So microcatheter, and then you take a selective picture, but also I connect the microcatheter at the popliteal to my pressure gradient, at the pressure, to see if there's any gradient. Did I miss? I mean, CO2 is not perfect.
Yeah,
So
yeah,
sometimes you do it and like there's like a 80 millimeter mercury gradient, and then you pull back and you find that actually there's a mid-SFA discrete
yeah,
lesion that the CT CO2. But you're absolutely right. So I actually use all the three wires. The advantage is great. The only disadvantage about the advantage is that you can't shape the tip.
Yeah,
I
that's
think
true.
that's the only thing. That's where Gladys, Mongo, and the command play a role. But yeah, I agree with you. I think all those three wires is, I think, what most common things. So here we just end up actually put wire first in the PT. I ballooned it gently. I got a reasonable flow, but the distal vessels are just not opening as much as I wanted it. It's just the perineal comes in as kind of light collaterals, and just shut down, and the PT also closed off. So we went with the Serration balloon here. It was actually used a very small Serration balloon, um, and we had a really good result. But because it's a single vessel with that wound, is worried about infection. We actually ended up using an Osprey on this one. And it was actually, if I'm not mistaken, it was a 3.0. I don't use short ones. I just go with a 38 most of my cases. I just don't feel there's a benefit to go super short in
Mm-hmm.
this way, because sometimes you do short one and you find like proximal has a disease and you end up having overlapping stent. I prefer just to do one scaffold. But
Yeah,
again, this
yeah,
case, if you notice, there's actually bend on that spot. So great to have no dissection and no disembbolization. This patient doesn't have a room for a complication.
yeah. And I don't, I can't imagine there'd be much difference in patency between a 38 and a, 22, or, you know what I mean? It shouldn't, they're both short, so it shouldn't affect it too much.
You've heard this. I think you've been on podiums about talking about the live BTK, and the comment that kind of it's I laughed at, but also a lot of interventions really get mad about is people when they start complaining, why is it too short? Why I only have 38? I need longer. Like, at least we have a data finally to a pause for a bioscopal scaffold or a stent for a positive result. So I think now all the other
Yeah,
companies, what they're doing at 48. There's longer. So
yeah,
hopefully we can get that more and more product, but I think none of them will work fine if you don't prep the vessel well. I think you prep yourself for stent thrombosis. I think when you get a nice expansion, you not worry about acute or late recoil. That's where that bioabsorbable scaffold can work very nicely.
yeah. Good point. There's some data in the supplement from that New England Journal paper looking at when patients needed 2 and 3 scaffolds. And it looks like there's not much decrement in patency at a year. So that's good also to know that if you have to use more than one, it doesn't appear to be, the cost is in the final bill, not in the patency. So that's good.
So Neil, I'm going to stop sharing, and I think if you want to take it from there.
Let me click on that.
Yeah, good cases. Very interesting. And Sammy, are you doing much retrograde these days?
I prep retrograde for every pedal case, and
Yeah,
I also prep. I do a lot of radial to peripheral, not in CLI, but I also prep pedal. I think pedal is an important. If you're going to do a CLI program, you definitely need pedal.
yeah.
It just helps us a lot. I didn't want to show it because it was not the assignment.
Yeah. That's not what we're working on, but very interesting. Yeah, go ahead, Neil. We can see your
Great.
screen.
Yeah, oh yeah. I'll echo that. I think pedal and radial access are huge. Even if it's just to get a wire across and you're still going to treat from above, having the foot ready to help you cross is very important.
Right.
So here, my first case. I wish I don't know how to get those great videos, but I have some pictures. So this is a 57-year-old gentleman, ulcers on the left foot. He's been undergoing wound care. Kind of got sent in to me late from his wound care center. Active smoker. So initial angio, his aortic segments clean, SFA and pop are clear. And I don't know about you guys, but a lot of the patients that I see in the hospital, are kind of disasters. You do an angio and you think, okay, this is going to be diagnostic. Everything looks great. And then all of a sudden you get to the tibial below-knee segment, and now you're wondering what you're going to do with yourself. So looking at the first picture, the popliteal looks good. The origin of the AT looks pretty good. The tibial perineal trunk is okay. It's hard to say. Like it looks like the perineal is the only other runoff down to the foot. But then when you get farther down, the AT essentially is occluded, and you can't really see at all where his dorsalis pedis is. This is a case where I'm kind of thinking like this would be a time where I'm like, if there's a nice dorsalis pedis, he's got vein, I'd be thinking bypass. But here, I could bypass to the proximal AT, and it's not really going to do anything for the wounds in his foot. So this is definitely one of those cases where it's an endovascular first scenario. Let's see. Does it work? There we go. So I did six. I went up and over. I would say that is my go-to technique. I use a long sheath, park it distally. But again, I'm not always 100% sure what's going to go on in the SFA or the common femoral itself. So I usually do go up and over with the foot prepped as well. So I was able, again, I used my 0-4 glide wire and Viper Cross, was able to get down the AT, and I was able to get across the AT, and you can see in this first picture, there is actually dorsalis pedis here. And this picture is actually after an initial treatment with POBA, a 2 by 100 millimeter POBA, because I couldn't actually get my catheter to cross to confirm I was in a real vessel, because in the initial picture you didn't see any of this. So use the POBA, and you can see here still it's hard to say what's going on kind of in this segment around the ankle. So then I used a 2.5 by 40 Serrator, and you can see here that that area that looked occluded is now open. Still not the best runoff into the foot. I would agree. I would have liked to get something around this bend, but it wouldn't track. But it also improved the collateralization to his foot, and his wounds did heal within 3 months.
Wow.
Anything
And
you would have done?
were they digital wounds?
No, he actually had an ulcer base of the first toe on the dorsal of the foot.
Yeah, I
Another
mean
scenario where it's like, is it PVD wounds? He had been burned actually getting a pedicure, so you're not 100% sure whether it's PVD or just a burn. But when it's not healing for 6 months, then you kind of know.
Yeah, that's a long time. Yeah. Well, and I think it's a kind of a case where if let's just say he didn't heal, because his runoff is so poor below the ankle, I mean, he would have been on my short list for
Yeah,
frequent follow-ups and also for pulling out all the stops. Any additional adjustments of any medications or anything else that I can do, make sure that he knows not to go to somebody that doesn't know him that could do
yeah,
something crazy. But I think if, let's just say it didn't heal, I'd think about recanalizing the pedal loop in this case, because, if he didn't heal, then you're either talking about going for the pedal loop or DVA.
yeah,
Those are your options.
yep,
And I think if you showed this angio and said, oh, well, let's say you couldn't make him any better, I think you'd be looking at one of those two options. So it's a good thing he healed up.
I would
Well,
say
we did.
the other thing that you can do here, sometimes it's just the vessel tell you a story. When the wire just doesn't want to go or you get there, sometimes you're surprised where that PT that didn't look, it goes nowhere. You put a wire,
Yeah,
you push it, and all of a sudden just go, because that's maybe the vessel that's dominant, and it's just so hard to tell when. I mean, this patient has a terrible below the ankle vessels, but I mean, it's funny. It's like the DVA has getting momentum, but it's not very, like, not a lot of people have a lot of experience with it as well. This
yeah,
patient is really having, it's just hard. I mean, those are bad vessel. And I just, when you're talking about taking pictures, like, oh, great, we're going to be done. We've been there, man. It just, you look great, proximal AT, just beautiful. We're going to be done. And you take it below at the angle, like, oh man, we're going to be here for 3 hours. So
yeah, exactly.
Yeah, good case. Interesting. Also a challenge from a decision-making standpoint, but definitely better when you finish. So it's a good thing he healed.
Yeah, I mean, it's better, and we see him. He's actually in the hospital. He does wound care once a week in the hospital, and so we're able to see him a little more often than just in our office. And so, keeping a close eye on it. I mean, if I went in and shot an angiogram right now, I would put money on that this is occluded, but it was enough to get it to heal for him.
Yeah,
Neil,
interesting.
are you doing any pedal acceleration time, or how are you? I mean, this patient doesn't have it. His toe pressure is going to be nothing. How are you following those? I mean, especially in cases like this where, just bad.
Yeah, a lot of it, especially this case. I mean, I'll do toe waveforms, but a lot of it's just clinically if the wound is getting better.
Yeah, interesting.
So next case, 6'7", he's got second and third toe amputations already. Now he's coming in with the remaining toes with ulcers. He's being worked up for a TMA. So his toes are pretty much gone already. It's really our podiatrist is asking, should I even do a TMA on him, or should I just give him to you guys for a baloney amputation? So again, this is one of those, everything looks fine up to the popliteal, and then you get hit with ridiculous tibial disease. And I think if you look at the first picture, the perineal is obviously the runoff to his foot. And again, I don't have a foot picture, but it's also horrendous. He's mostly collateralized, and we're doing this to get him a TMA versus a baloney amputation. But you can see, tibial perineal trunk looks okay. Tight lesions throughout the proximal perineal artery, and then it really is okay. Like you said before, you wonder where the wire goes. And I actually wanted to try to get into this anterior tibial and see if maybe there's something we could do, because you can see maybe it comes back down here, lower down. So was able to get a wire, you can see, coming down into the perineal. Luckily for me, I didn't have to make any decisions about origin. Both the origins looked okay. Treated the perineal with a 3x40 Serenator balloon, and then surprisingly was able to get down the AT, not all the way to the foot, but at least to the ankle, and did treat that with a longer 2.5 balloon. I did not IVUS, so these are based solely on my kind of clinical judgment. You can see that it's not perfect, and it's not all the way down, but definitely improved collateralization in the AT. And then the perineal is intact down to the foot. You could say maybe I did think about going to this PT as well, but again, with nothing farther down, I thought it was just futile at that point. Would you have gone after that, or just stayed there?
I personally would not. I don't think you would go anywhere in that PT.
Yeah.
I think you said it. You're looking for a TMA to heal. You want to make sure that I think this patient has a perineal dominant vessel.
Yeah.
So you gotta get that perineal as big as possible. And this looks beautiful result. I actually got a question for you, and Peter, also for you. Now we have other technology for below knee, like for example, Javelin IVL. I've been using a combination of Javelin Serration together. Javelin to get that tight lead, and that I'm wondering if I can crack that calcium in it, and then the Serration is more for gonna expand the vessel without worrying about a dissection. What do you guys think about a combination therapy?
So I would love to do that, and that would be my algorithm. At this point, my hospital VAC committee, I have not got Javelin in yet, but that 100% would be my algorithm. There's so many times that you can get a wire, but nothing else will cross, and having Javelin just to make that path for you, and then you expand the vessel later on, that would be definitely good. I would like that.
Yeah, interesting.
Again, always, there is this time there's some disease in the SFA popliteal. You can see on the angiogram, nothing's really filling very well. I saw this lesion at the origin of the anterior tibial artery, and thought maybe it looks kind of like that is the dominant runoff, and then everything else is kind of missing. So I was able to get the balloon across, and you can see here at 2 atmospheres. So I guess a side point, when I do these, I don't know what your guys' algorithm is. I'll go very slowly, maybe 30 seconds up to 2 atmospheres, let it expand, and then go to, full, then to 4 for the remainder of the first minute, and then to 6 for the second minute is how I'm inflating these. Sometimes I'll even just stay at 4 for the entire 2 minutes, but the first probably 30 seconds, I am slowly inflating up to 2 atmospheres only.
Yeah, I like that. It's a good way to do it. I like the idea of doing it slowly, and you do want full effacement of the balloon. Sometimes you can watch, I mean, you're just sitting waiting and you'll see that it's still expanding. So I think
Yeah.
doing it slowly makes sense. And if I have any, like in a lesion like this, if I have any question about it, inflate it, get to 4, and maybe deflate it, move it a little bit, either, more distally, whatever, and do it again, so to create more serrations in a otherwise difficult area of an orifice or origin lesion.
So yeah, so it was.
Yeah, I do the same, and I think it just depends on if I'm oversizing a little bit. I definitely do the same. I just want to I look for the dog boning picture, and then I just let it slowly build up. But sometimes if you undersize, you think it's a 3.0, it's a 3.5. I go with the 3.0/40. I'm just inflating, and I just miss the dog boning, and all of a sudden I'm already 4. So
Yeah.
I think it's important people just gonna for us all just gonna look slowly go up and just keep an eye on the pressure, because that's exactly what Neely said. I mean, it is you want to go slow and steady and let it sit for a minute or so.
So yeah, so then in this case, you can see after that time, it's essentially expanded. There's a little bit of a waste here at right where it comes off. But I did try to go into the tibial trunk PT. That was just plain old balloon. But a nice result in the AT, which was in line down to his foot. So this actually was intact to the foot with the origin there. And then my last case was more of an acute on chronic limb ischemia. The patient presented with paresthesias, pain, had a CTA that showed an acute cutoff in the popliteal artery. Everything else was pretty clean. She did have atrial fibrillation, had been on Eliquis, so we're thinking that's where it's coming from. But when you see this angio, to me at least, I see this acute cutoff. However, look at all these collaterals is saying there's something else going on here, not just an embolus. Would you guys agree with that, or?
I mean, it's more collateral than you usually see. I
Yeah.
mean, you see the AT lighting up in a way that if you just get a hot popliteal embolus into a normal
Yeah.
artery, you don't usually see that.
Yeah, I mean, one of the possible option for acute limb, as you guys know, it's in situ plaque rupture, where we see in the heart.
Yeah.
So this is the MI of the heart, of the MI for the
Yeah.
leg.
For
So I think this
sure.
might what happened. You have a plaque there, just plaque rupture to close the vessel, and that's exactly right. I mean, there's so many collaterals, but the way it stops, there's a thrombus sitting there.
Yeah, for sure.
Yeah.
So I decided, in this case, trying to think, are we gonna lyse the patient? She had symptoms for a while. Is it even worthwhile trying to get through? Where is the wire going to go? So I did try and was able to get a wire down into this AT, confirmed that, placed a micro multi-infusion catheter across this lesion and gave her 4 milligrams of TPA. Waited. I wanted to wait 15, but I only waited 10 because I just couldn't stand it for that long. Used a Cat7 penumbra device to suck out mainly the AT and the origin, or sorry, the popliteal and the origin of the AT. Also used the CatRX to go in and suck that out. And then on the next angiogram had severe noticed lesions at the origin of the AT and the tibial trunk. So used a 3x40 millimeter Serrator balloon. And in the first lesion here, you can see this waste kind of at the origin of the AT, which is gone in the second picture. And then this wire is down in the tibial trunk with the balloon inflated. And there's our final picture after suction thrombectomy and treatment of the origin, kind of right in here, and the origin of the AT. Some spasm here. I don't know, would you guys have gone after this? I didn't with everything we did, it wasn't on the initial angiogram, but it did come. It was here now. I didn't know whether it was my wire, whether running the RX and the 7 down. I wasn't sure, but it looked good, and she had a palpable pulse. So I decided, that's it for me.
I would leave it
Yeah.
alone. I would
Yeah, I
definitely
probably
leave it
would
alone.
too. Yeah. And also that wasn't the pathology she started with. So as long as you don't see a filling defect,
Yeah.
I would probably leave it. But and then for a patient like this, so did you put her on anticoagulation afterward?
Yes.
Yeah.
Yes. Switched her to Lovenox. She had been on Eliquis. Switched her to Lovenox, and we'll figure out what the next best step is with her hematologist.
Yeah,
Yeah.
Neil,
Yeah.
I would say if one case will convince you to do IVUS, will be a case like this. I think after you did your thrombectomy, throwing an IVUS there may give you a lot of information. We can tell you if
Yeah.
there's a plaque rupture there, ulcerated plaque, something like that, or just a fresh thrombus. But using a low, there is no calcium in this case at all. So I think, nothing else needs to be done. I think you already did a thrombectomy, you already did TPA. The last thing you want to do is use a regular balloon and end up with a massive dissection that you have to put a stent and you use a
Exactly.
permeable. I think that's where really a really good case to show that you go for a low inflation balloon that pre-safe, low risk of dissection, which is what Serration balloon can provide here. A beautiful result.
Yeah. Agreed. Agreed. Anyway, we're getting up to the top of the hour, and I know it's probably getting late on the certainly on the East Coast. But I want to thank you guys, Neil and Sameh, for
Thank
joining
you.
in and showing these cases. And it's always amazing how, something we feel we understand and know so well, you always see something different or new or some combination of disease or some watch out that we kind of learn from and kind of draft off each other. So that's a lot of fun, a lot of good points made, and so I think we'll close it there. I don't know, Neil, any final words of wisdom?
No, I think we covered everything. I think going slow and sizing correctly is very important. I think the IVUS is very important because you're going to want to size low or undersize, but it's really help make sure you get that one-to-one sizing.
Yeah, yeah. And Sammy,
I would say
anything to leave the audience with?
I mean, I would say in general in life, but below the knee specifically, cutting corner never help. And I think just run a quick and just a balloon and come out, this patient not going to be served well. So I think spending the time to really modify those lesions is extremely important with any tool and any time. And just as Neil said, even with serration balloon, if you just inflate it for 10 seconds and deflate it, you're not taking the benefit from it. So just take your time, and this is what the patient benefit from.
Yeah, agreed. Okay, well, good. I hope you guys can take the rest of the day off there in Texas and New Jersey.
Thank
And
you.
thanks a lot for joining in.
Thank you very
Thank you.
much.
And thanks to the audience. Thanks for being on with us. All right. Have a nice evening.